All right, welcome to the Deuk Spine Institute's live stream. This is our last surgery of the day. Our patient, which you'll see in a moment, has had fusion done by another surgeon, not me. And this needs to go back just a little bit. This whole mayo right there is fine. And unfortunately, they got to him before I did. He's got, honestly, really... how's blood pressure? Yeah, we get it down, please. None. He's got, you could see the hardware, right, Jordan? Let's show the audience on the x-ray, Henry, what's happening here. You've got screws, and they are, honestly, I hate to say this, but they're too far out of the bone. The screw head, the tulip, should be much deeper. Right there, see where the white arrow is? That's where the screw head should be. It's for some reason way out, and I think I know why. It's this shitty, minimally invasive fusion nonsense these doctors do. They sell their patients on just to get their money. But show them this where the screw head is at S1. Look at the S1 screw head. Go down a little bit. That's right there. That's where the tulip that holds the rod, at the base of the tulip, okay? Where should that be? Right there. Look at that, where the white arrow is. That's where it should be. So these screws are literally 2 centimeters to 3 centimeters too long. They shouldn't be that long. But they do that so they can put the rod in easily up in the muscles. So basically they destroyed his muscles, putting this stupid hardware in that's totally out of place. Is that my latest shot right there? Okay. All right. And at the same time, they put those stupid cages in. Show them the cage. It really upset me because the cage is too small. It's not tall enough. It's too short. And it's also put in a way that there's still herniation left in his back. In other words, they didn't take the herniation out. So now I'm going back into that L3-4 disc to get rid of the herniation on the right side. You guys understand what I'm saying? Shot? In other words, they didn't do the job of getting rid of the herniation of this poor man. So he's been through a huge surgery, a fusion, that he's been in pain from for years, and they didn't even take the herniation out. So I got to go in there and take it out. All right. I'm heading for the L3-4 disc. He's also got horrible facet pain. How's he doing? Is he okay? I'm slipping around the facet right now as we speak.
All right. Okay?
Lay still. Well, we shouldn't have woken the sleeping giant. All right, get an AP. So on the lateral view, the needle is approaching the herniation on the right side. Looks perfect. Let's get an AP view. Yeah, perfect. Look at that. You guys see the cage? Show them the cage. Stay there. Show them the cage at 3-4. Okay. The other problem is there's no cross link. Okay. There's the cage at 3-4, and the herniation is off to the right side, right over there. Show them where the herniation is. A little bit. Yep, right there. No, you had it right. Go left to the left a little bit. That whole area there. Circle that area.
Gotta keep your head down,
there.
sir.
That's where the herniation is.
Keep your head down. You're on a narrow bed.
All right. Let's go back to a lateral.
Okay? Please don't move.
You're doing great. Lay still. Okay. You're doing fine. We're almost done. We're going to be able to put you to sleep in a minute. It just makes me so angry to see these metal-happy surgeons just popping tons of metal in people and ruining their lives, basically. All right. So here we are, shot. We're entering that herniation. I could feel it. I could feel the metal right there. I'm touching it. All right, we're in. We are in the L3-4. Let's go ahead and do our discogram, and then we're going to go in and take care of the herniation. I've got to be careful because this is a bit of an unusual situation. Shot? Is that it? All right. So much scar tissue. The dye isn't even going in. There's just no way to get the dye in. It's just not going in. The disc is really scarred from the surgery. Anyway. So This is going to be a little different than how we normally do surgery. Skin numbing. You okay? Lay still. You're doing great. We're going to put you to sleep. I want you to count from 1 to 100 out loud. We're going to make our incision. You're doing fantastic. When you wake up, we'll be done with your surgery. So I feel bad because this is a really, you know, number one, he got a fusion, which he didn't need. Number two, the fusion is not even well done. It's poorly done. But taking all those screws and rods out is going to do more harm than good. So I'm going in. You're okay. Let's give some num-num. I'm going to give you some more numbing medicine, all right? I'm sorry? Yeah, that's fine. I'm just giving him more of the numbing. There's a lot of scar tissue here, Sean. The scar tissue comes from the surgery. Scar tissue bleeds. Sean? All right, I'm heading towards that residual, we call it a residual herniation. Just to understand what's happening here, the surgeon didn't take the disc out and left disc material over here on the right side. He's also got a herniation above this at 2-3, but I'm hoping this is going to fix this problem. He's got adjacent segment disease. You can see the L3-L4 disc is just collapsed as well. But anyway, I want to try to take care of one problem at a time here, and I think he's going to get some good relief with this procedure. I'm up against the cage. So we're going to go in there and we're going to see this cage. Endoscopically. Yep. So we're literally going to put a tube down and we're actually going to see this cage at the base of this tube. And I'm going to clean out whatever herniation I can that's to the side of this cage that's getting in the foramen. Stop. All right. And there it is. So, take it. You don't need that. Is it in there? Wedged? Shot? Looks good. So you see that? We're literally transforaminal through the foramen that's already there. We're inside that L3-4 disc on the right side. And I'm going to try to remove as much of that herniation as I can that the other surgeon left behind and try to help eliminate his pain. After we're done with this disc, we're going to move on to the facets because I think he's got facet pain. Wait, yeah. He's doing great. Any questions?
No current question.
All right. Well, welcome to our live stream. This is unfortunately what we call a patient who's had their back already operated on with screws and rods and fusion. And I'm going to go in and try to clean out what's left that the surgeon left behind, which I saw in the MRI. And I'm going to try to get some of this out of here because it's pushing on his nerves. I have a feeling we're going to end up seeing the cage down here. Let's go laser. See that inflammatory tissue, the pink stuff? That's where his back pain's coming from. And his leg pain. Take this.
Oh, I have some for you, yeah. Thank you.
I always tell people rather than go out and get fusion done or laminectomy, get the better surgery done first. Because those other surgeries, they just mess up your back. Mess up the muscles, the nerves, everything. Here's bone spurs inside the herniation. You see how the laser just eliminates them very easily. This is inflammatory tissue right here. I think that's the cage. There's the cage. You guys see the cage? Look at that right there. You see it, Hen?
Yes, we do.
Yeah, it's kind of hard to miss, right? Anyway, this is exactly what I hope to be able to do for him. I want to find the cage. I want to go deep enough so I see the cage. And then I want to pull back. As I pull back, I'm going to clean up the herniation that was left over here on this side. Okay? Look, I don't blame surgeons, other spine surgeons, for wanting to do less invasive surgery for patients, but there's an old discussion and debate in the field of spine surgery, and that is, you know, if you cannot compromise the results, and you can't go so minimally invasive that you don't get the results you need with the patient, right? Look at all that inflammatory tissue right there. It's all pink. That's where his pain's coming from. Okay. Cleaning it out. So in other words, if you have this tug of war between less invasive procedures and less effective procedures, and you really want to have an effective procedure that's the least invasive. Effective means
DLDR.
that's the DLDR, right? So this surgeon that did this fusion tried to do a less invasive fusion. He's still doing a fusion. The fusion can be a good surgery. I just did one this morning. It can be a really good surgery if it's done properly. But notice that I didn't do it this way. I didn't do long screws, percutaneous screws. I did it the right way. I opened the patient up. I got in there. I did the osteotomies. You can't do that minimally invasive. There's no such thing as a minimally invasive osteotomy. Not yet. I might be the one to do it, but anyway, long story short, you cannot compromise results, good outcomes, just to get less invasive, so you can say I did it less invasive, okay? By the way, this is all scar tissue around the cage. See the cage? Pretty cool, huh? Go in and see this cage like that, made out of metal. All right, I'm gonna pull back. I'm gonna get the annular tear, a little bit of bleeding. It's from all the inflammatory tissue. Almost done. Hoping this takes care of his pain.
We have a question.
Sure.
This comes from Ray on YouTube,
Hello, Ray.
and they asked, how do you plan to address the facet pain after you deal with the herniation?
Ray, you're so funny. I love it. You're reading my mind, Ray. Well, I'm going to go in and do the Deuk plasma rhizotomy. As soon as we're done right here, which is going to be in the next couple of minutes, I'm going to go in and do the plasma rhizotomy. And you know what? I'll broadcast it for you. How's that? Okay? And you can watch it. See how I do it. Basically, facet pain comes from a small nerve. We know where it lives, and if we kill that nerve, then we can get rid of facet pain. Now, this patient has horrible pain on the right side, and that's where we are. We're on the right side, and it's right here at L3-4, L4-5. So I've gotten rid of the herniation. There's no more herniation left. Maybe a little bit right there. I'm going to do that next. That's lateral. And then we're going to do our facets. Okay? So great question. Here we go. Here we go. Okay? That's the last of the herniation right there. And you all saw the metal cage. Kind of nice view. Endoscopically seeing an inner body cage. We've done a couple of these now. They've worked really well. That's why I'm willing to try it. I don't do surgery that doesn't work. I've never done a surgery that doesn't work. That doesn't mean that I've cured 100% of the pain with every surgery. It just means that the surgeries I've done for a specific purpose, a specific type of pain. And some people have more than one type of pain. They've got 2 or 3. So we've got to do several different treatments. This is an example. This patient doesn't just have disc pain. They've also got facet pain. So I'm going to go in and I'm going to take care of his facet pain as well. Okay? Hopefully that fixes his problem. All right, done.
Lights on, please. Thank you.
I'm going to clean this out. It's a little betadine. Any questions? Let's go ahead and show our video on how does a disc herniation actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We have finished the Deuk laser disc repair part with L3-4 right side. I slipped in underneath his fusion, underneath his rods, went into the disc, found a herniation, found some bone spurs, found inflammation, and zapped it away with a laser. We also saw his cage that was put in there by the other surgeon. Now we're going to go in and treat his facets. Okay? So you guys are going to get to watch the very first broadcast in the history of the world of the Deuk plasma rhizotomy. This is a rhizotomy that we developed here at Deuk Spine Institute. Been doing it for 25 years, but by itself in patients with facet pain, we've been doing it now for about 9 months. Every patient we've done, we've gotten rid of their facet pain. Shot. So most of this is going to be done by X-ray. All right, we know the screw at the top is in 3. I need to see a little more of the transverse process of 3. Swing around or come to me a little more. Come to me. So what I'm going to do is I'm going to find on an AP view, I'm going to find you need to rotate or something. I need to find where the transverse process of 3 joins to the pedicle. And keep going, that's my target. Shot. All right, I'm not seeing the TP. Yeah, I see the TP at 4. I don't see the TP at 3. All right, we're trying to darken it up. There it is, I think, right there. I see it now. So he may have a little bit of osteopenia. Let's go back to a true AP. Shot, that's it right there. Try to bring the camera in from above the fusion, above the rod, above the screw at 3 on the right. Now notice for those surgeons out there what I'm doing. I want to see that corner right where the screw penetrates the pedicle. You see it? I wonder if you can angle it. Look at me. Bring the camera this way and towards me. Towards me about a few degrees. Let's see if that helps. Open up that space. Yep, shot. All right. It's actually not bad right there. I can live with that. You see the transverse process of 3 better right there. You see it? I just wonder if you could show me that corner a little better. Show us the corner so the audience could see. Yeah, that a little bit to the left, a little right there. That where the arrow is right there is our target. Okay, I need to see that a little bit better. I could do it right now if I had to, but I'm gonna. This is very important for spine surgeons. You want to optimize, maximize your view with the X-ray. Okay, before you start. Play with it. We got a few minutes. Yeah, keep going. Come towards me with the whole base. Bring the base towards me, and bring everything to me. The whole contraption. All right, try that. All right, we're getting there. We're literally almost there. I think you have to bring the whole thing more towards me again. Shot. Now, it's not bad. We're just about there. Literally a couple of degrees off. If you can show me just a little more where that TP connects to the pedicle. Shot. All right. That's not bad. You know what? I think we're off on the TP now. I don't see the TP anymore. Do you? Yeah, I think we got to do less. I can see where the transverse process, I could see 4. You want to just do 4 right now while we got it? We'll come back to 3. Shot. Let's see. So that's looking good. Shot. It's a little superior. There we go. Shot. Right on the exact spot where we need to be, right there. Very deep, but that's perfect. Let me see. Shot. That's perfect. Yeah. So that's the, show us the arrow. Show us with the arrow exactly where I am. You guys see where the tip of this needle is? It's literally in the most perfect spot. There shows the transverse process of 4. Yep. Outline it. Looks like a finger. Yep. And now go along the top where it connects to the facet. Right there. That's the perfect spot for rhizotomy. Okay? So that's where we're going to go. That's where we want to be. All right. Did you whittle? Yep. Nice. I love it. Now we're going to go in with our probe. Coke. Let's see where we are. Shot. All right. So we're too superior. I'm going to head towards that beautiful spot right there. I threw the fascia shot. Too superior. Need to be further inferior. There it is. Shot. That's too lateral. We need to go more medial. Shot. That's better, but still not medial enough. By the way, folks, in case you're wondering, what does medial mean? It means towards the midline. Shot. That's almost perfect, but not quite. We need to be perfect. I think that's as good as I can get. I feel the facet right there. You guys see that? Perfect position. So now I'm lighting it up. I can feel the screw. I want to make sure. Shot. Gosh, that's beautiful. Let me get it out of the way. Shot. Beautiful, beautiful, beautiful. I'm going to do a little more, because more is better. All right, I kebabbed the medial branch of the dorsal ramus. It's kebabbed. So that's 4. Now I got to do 3. Is that 3 right there? Is that 3 that I'm seeing? Show me 3, where you think 3 is. I think I see it right there. Yeah, I see it. It's just a little dark. Yeah, that's 3. That's 3. All right, so let's see if we can reach 3 through the same incision. I should be able to.
I want to say hi to my daughter who's watching. Hi, Brianna.
Hi, Brianna. Dad says hi. Shot. You think that's 3 there? I think that might be osteophyte. That's the problem. See the osteophyte? I can't tell if the 3 is over superimposed. We're going to need to do better on 3. Bring the whole fluoro to me. Move it about an inch. And then you can rotate back a little bit if you want. Yeah, there's definitely a huge osteophyte. I don't want to make the mistake of cooking the osteophyte. You gotta, I mean, it's too dark. You gotta lighten it up a little bit. I think that's the transverse process of 3 sitting on top of an osteophyte. I think we're a little north of it here. So I'm gonna head south. That's 2 south. Shot. I think that's it. What do you think? Right here, I feel the TP. Shot. Let's do a lateral view just to make sure. I mean, it's the same depth as the other one. I think it's the right place. So we are going to just check our lateral view quickly to make sure we're not past the facet down by the foramen, which I don't think we are, but I want to verify that. The thing about spine surgery is if you just, there we go. Yeah, we're right where the screw penetrates. You guys see that? Show it, Jordan, right where the screw enters the pedicle. Right there. Yep, that's it. That's where we are. And that's where we're supposed to be. So let's go back to an AP. Go ahead, numb it up. And actually leave it in there until we get a good shot of it, because I want to make sure we don't lose our mark. So we're doing 3 now. We already did 4. We got to go down and do 5. That looks good. I could live with that. Okay, very nice. This is going very well. We'll be done in 10 minutes. Doctors. Any questions from our audience, by the way?
No current questions.
Shot? That feels pretty good right there. Let me just see where we are. Shot? Yeah, it's beautiful. It's absolutely beautiful right there. That is the spot. So if you know your anatomy, and by the way, just for those of you who don't know much about me, neuroanatomy was my subject. I mean, literally, if you want to be a neurosurgeon, you got to know your neuroanatomy. And I loved neuroanatomy. That's what made me fall in love with the brain and the spinal cord and everything else that made me become a neurosurgeon, was my passion for neuroanatomy, which is why, of course, Dr. Roten chose me to be a resident, because he loves neuroanatomy. All right, we need to see 5. Let's go south, and you need to come to me more. You can see the transverse process of 5. I see it. You guys see it just below the needle? Like a little finger sticking out? Oh, I saw it better earlier. All right, but you need to come more to me, I think. And then rotate a little bit around the screws. Try that. Let's see what happens. Yeah, that's not bad right there, actually. That's pretty good. Uh-huh. All right. So I need to try again. Shot. Let's see where that is. I think I'm hitting the screws right there. I am. I lost the TP. I don't know why. I cannot. There it is. I think I see it now. There's a ton of scar tissue here. I can literally feel it with a needle. It's crazy how much scar tissue there is from his surgery. Now, why is there scar tissue? Okay, this is the secret they don't tell you, these surgeons that do quote-unquote minimally invasive fusion. The scar tissue is from dead muscles. They kill your muscles under your skin. You can't see it, but it hurts like hell after the surgery. And you pay the price because all that muscle's dead. I feel all the scar tissue. That's it. We're in perfect position. It's a big lie They give you a small little incision on the surface, and underneath there's a nuclear bomb that went off in your body. It just killed all your muscle and turned it into scar. It makes me so angry, the deceitfulness of this. I want nothing to do with it. That's why I do my fusions open. I do them open because it's safer and better for the patient. And I'm not trying to lie to them and tell them, oh yeah, we're not doing any damage. What's this here for? Okay? It's all about integrity and honesty. Oh. Let's see. I'm not sure where that is. Oh yeah, too lateral. Way too lateral. All right. Shot. And by the way, if you've ever done this stuff, it's not a problem to be out of place back here. You just have to correct it before you turn the rotisserie on. Shot. That's looking good. This is our last one. And I'm there. I could feel the TP. So the rotisserie is, of course, when we cook this thing. And that's why we're here, folks. We're here to cook this bad nerve. It's been a bad little nerve. We're not cooking the nerve root, by the way. We are cooking the medial branch of the dorsal ramus, which in the world of spine, it's the pain nerve to the facet joint. Shut. It's beautiful, beautiful. By cooking this nerve, you get rid of all pain that comes from the facet joints, which I believe this patient's having pain from his facet joints. I'm bouncing on his transverse process. We're done. I can feel the screw. There is one other possibility for this patient, and that is that those screws are causing his pain. So if this procedure gives him relief but not total relief and he still has pain, he's going to have to get those screws taken out because they're way out of place. They're way too proud, and they're sitting in his muscle, rubbing against his muscles. Just a horrible technique. All right, done. Great job, everyone. You guys got to see the first broadcast ever in the history of the world. Deuk plasma rhizotomy. It is in the process of being patented. And everybody will be doing it because it's better than a radio frequency ablation. Thanks, everyone. Great work today. All right, if you have questions, are there any questions?
No current questions.
All right, have a good night. We're tired. We're going to go to bed soon. We're all getting old. We all need to go to bed soon. So good night. We'll see you in a couple of weeks. Thank you. I call the EBL 2 mil.